Dear audience, it's a pleasure to be here and talk about my PhD topic, which is procalcitonin guidance for optimal antibiotic therapy in critically ill patients. My name is Márton Papp. I'm a second-year PhD student and an anesthesiologist specialist working in Semmelweis University. My vision is that one day every patient will get appropriate antibiotics, and to achieve my vision, my mission is to protocolize and individualize procalcitonin use in everyday practice. Here you can see my specific goals. My first goal is to investigate the effects of procalcitonin-guided antibiotic therapy versus standard treatment in critically ill patients with the methodology of a systematic review and meta-analysis of randomized controlled trials. We know that inappropriate antibiotics has serious adverse effects like emerging antibiotic resistance, which caused almost 700,000 deaths in 2014. But on the other hand, the current sepsis guideline tells us to give antibiotics early, immediately, but ideally within 1 hour of recognition of the septic patients. We know from previous randomized clinical trials that we could reduce the length of the treatment with using PCT with a median of 2 days, but it is still unclear when to start and stop the therapy safely and whether this PCT-guided management can serve this purpose. So our aim was to investigate the efficacy and safety of this PCT-guided management. So does procalcitonin-guided antibiotic therapy reduce the length of treatment without causing harm in critically ill patients? Our patients are adult patients treated in the ICU. The intervention is PCT-guided antibiotic therapy, which means there is a predefined PCT protocol for starting and or stopping the treatment, which can be overruled by the treating physician. The comparator is standard of care without PCT guidance, and our outcomes are length of antibiotic therapy, mortality, recurrent and secondary infections, length of stay, and cost. And we hypothesize that PCT-guided antibiotic therapy reduces antibiotic usage without compromising patient outcomes. And if we could reduce antibiotic use, we could reduce antibiotic-related adverse effects and even healthcare cost. After the selection, we have 26 articles for the quantitative analysis. The length of antibiotic therapy was our primary outcome. The outcome measure is mean difference in days, and in this plot you can see that in the PCT-guided group, the antibiotic therapy was nearly 2 days shorter, which is a clinically relevant difference and even statistically significant. Almost you can see with quite heterogeneity, and you will see the relevant risk of bias and grade assessments on the relevant plots. Our safety outcome was 28-day mortality, which is seen in this plot. The outcome measure is odds ratio, which is 0.84, which means that in the PCT-guided group, the 28-day mortality was 16% lower, which is clinically relevant and even statistically significant. The sepsis definition has changed in the recent years. The sepsis 1 and 2 said that very aspecific definition that infection plus this so-called systemic inflammatory response syndrome is called sepsis. But despite of that, the new definition says that sepsis is a dysregulated, is a life-threatening organ dysfunction caused by a dysregulated host response to an infection. And here the emphasis is on organ dysfunction, which is defined as an acute change in the so-called SOFA sequential organ failure assessment score with 2 or more points, which reflects an overall mortality risk of approximately 10% in a general hospital population with suspected infection. Therefore, this definition defines a more homogeneous and more ill patient population. And in this patient population, the length of treatment was even more reduced with 3 days. However, the difference was not statistically significant, maybe because of the lower sample size. But if you looked for 28-day mortality in the sepsis 3 cohort, it was more than halved, which is, of course, quite clinically relevant and even statistically significant. Our other safety outcome was recurrent infection, which means that the same pathogen causes an infection at the same location as the primary one. And here you can see that it is nearly 1.4 times higher in the procalcitonin-guided group. However, if you look for the details, the overall event rate was quite low, below 5%. The strengths that we used only RCTs with a high number of patients, high number of articles, but of course we have several limitations like high heterogeneity regarding infection type and severity, the use PCT protocol and standard of care, the different degrees of protocol adherence, and the lack of reporting and antibiotic appropriateness, and the exclusion of immunocompromised patients. But at the end, we can say that we can reduce antibiotic use with PCT guidance, especially in those regions where routine antibiotic administration exceeds 7 days. It is maybe accompanied by higher rate of infection recurrence, but on the other hand, it may be associated with lower 28-day mortality. And the implication for practice, we should individualize antibiotic therapy, and we should use procalcitonin as a part of the so-called sepsis puzzle. And maybe the actual guideline, the procalcitonin, needs a higher support. And we have several implications for research. The aforementioned guidelines contains a weak recommendation against using procalcitonin when considering starting the therapy based on 3 previous RCTs, but we think we need new RCTs investigating this issue, as well as new RCTs investigating different patient populations and protocols, the high odds of infection recurrence, and we should use organ support 3 days instead of mortality. Long story short, we managed to publish our manuscript in Critical Care in last October, and maybe underlying the importance of our results, we have some appearances and rewards on sepsis conferences here and the Semmelweis Symposium too. And as I mentioned, we need RCTs investigating antibiotic starting using procalcitonin. Therefore, our second project is investigating PCT kinetics to guide antibiotic therapy of critically ill patients with suspected new onset infection. This is a protocol of a multi-center randomized trial. We know that every second patient is considered as infected in ICU, and the infection alone can double mortality. However, only 40% of our patients with the initial diagnosis of sepsis later confirmed to have infection. Therefore, the diagnosis of infection could be quite challenging. We should use PCT, as we know there are a lot of studies, but we don't know that absolute PCT values or the kinetics is a better predictor of infection. Therefore, we would like to investigate this issue in this RCT. We plan a 3-arm trial. Can we decrease unnecessary antibiotic use with the help of PCT kinetics in critically ill patients? Intervention 1 is antibiotic initiation using the kinetics of PCT. Intervention 2 is antibiotic initiation using absolute PCT values. And the comparator is antibiotic initiation without PCT use. And our primary outcome is rate of unnecessary antibiotic therapy. Secondary outcomes are organ support 3 days, length of stay, mortality, number of multidrug-resistant organism-caused infections, C. diff infections, and kidney injury. And our hypothesis is that using the kinetics of PCT can reduce unnecessary antibiotic use without compromising patient outcomes compared to absolute PCT values or usual care only. And the implication is the same, reducing antibiotic use and related adverse effects. We would include adult ICU patients who are hemodynamically stable with a suspected new onset infection on admission or during ICU stay when the source of infection is known or highly suspected, with 2 available PCT values and with properly done microbiology sampling. We would exclude infections if long-term antibiotic treatment is recommended, when the adequate source control cannot be guaranteed, when the infection is indisputable, admissions after cardiopulmonary resuscitation, when the chance of survival is too poor, and with known pregnancy. And here a quick look for the trial in the arm A, kinetics arm. If the PCT elevation is higher than 100, higher or equal than 100 and 150%, antibiotic initiation is encouraged and strongly encouraged respectively. In the absolute arm, if the PCT is higher than 0.5 and 1.0 nanograms per milliliter, again, antibiotics are encouraged and strongly encouraged respectively. In the control arm, we would start antibiotic regardless of the PCT value. We will measure it, but clinicians will be blinded to the results. Here again, the outcomes, the most important primary outcome is the unnecessary antibiotic therapy. There will be a reassessment after 72 hours of therapy with all the relevant data, clinical, microbiological, lab data in hand, and the multidisciplinary team will decide if the therapy is necessary or unnecessary. Now we are at the stage of sample size calculation. Here you can see the summary of my projects. And I would like to thank you for your attention with Bertolt Brecht's quote, "He who fights can lose, he who doesn't fight has already lost." Thank you very much.
Thank you very much. Very nice presentation, very thoughtful actually. I liked it a lot. Can we go, I mean, before asking the others, then can we go to the recurrence of infection? Just to ask a tough question, maybe easy actually. Okay. But I mean, altogether, it looks like that PCT guidance is a good thing, except this was the only kind of thing which turns to the reverse when it says that the recurrence. And also, since you actually have a design of actually a clinical trial, so you probably thought about this, that what is the cause of this, and then how could it be actually avoided? Or this is just, I mean, maybe a small sample size.
Yes, you're absolutely right. This is an undesired effect, because we suppose that we would suppose that if we give less antibiotic, or yes. So the problem or the cause of this could be the big heterogeneity. And we couldn't exclude bias, as one of the authors of the paper said, that maybe in the PCT group, clinicians think of a reinfection sooner than in the other. So I think I can agree with the author of that paper that we couldn't exclude bias. And to tell the truth, it is not, there is no exact definition for infection, there is no exact definition for reinfection, and there is no exact definition for secondary infection. There is also nothing is 100% sure, so maybe we must calculate with that. Also, although we have everything in our hand, maybe we can't decide properly that, oh, this is now just colonization with this pathogen, or it's again an infection. So I think this is what is behind this result. There is a newer meta-analysis. I know one more since ours was published, and they made different subgroup analyses, and they didn't have the same effect. So maybe it is not. It is more important, or other important thing, that what we are talking about, because sepsis is a very heterogeneous syndrome. Even sepsis redefinition, it is. We can talk about urinary tract infection, respiratory tract infection, and so on, and it depends on what infection are we talking about.
Thank you. So you have to be kind of open-minded on this.
Yes, actually, we wrote to the reviewers, and the best would be to make an individual patient data meta-analysis and look for the exact infection types, because we know from previous meta-analysis that respiratory tract infection is a very well-defined set of people. And there are very good recommendations, for example, to use PCT in this setting. The FDA has a recommendation for using PCT, but the problem is that our patients are more heterogeneous.
I'm very, very sorry, but there's no heterogeneity on this part. Sorry. Anyway, so great job.
I think maybe there is, because the confidence interval is from 0 to 58. the I-square test, so it could be 0, but it could be 58. So yeah, the p-value
I'm
is
outweighed.
not significant.
Okay, that's okay.
Of
Yeah,
course.
it's the upper bound is slightly above 50%. I'm very sorry. So in the introduction, it was that like medicine already knows that procalcitonin guidance is good, and you wish to come closer to the start, like the when and till how long. Did you get any closer to these?
We know we have much more evidence regarding PCT usage when stopping the treatment. The problem, but we don't know exactly how to use procalcitonin. We know, and our results said that we should use it. It must be the part of the everyday practice, but we don't know, for example, which protocol would we use. I mean, we don't know how long should we wait until the PCT reaches the 80% of the peak value, the 90% of the peak value, 0.5, 0.25. But in our article, we made suggestions about that because we make a subgroup analysis. We called two groups like liberal and conservative strategy regarding stopping the treatment. It is not in these posts, but it is in the article, and our results overtly suggest that it is not necessary to use too restrictive stopping thresholds. We should be more liberal, but new RCTs are needed to prove that. Regarding the other question, starting antibiotics, the actual guidelines tells you not to use procalcitonin plus clinical evaluation because they have these 3 previous RCTs, and they, because of these 3 RCTs with a substantial number of surgical patients, say that you shouldn't use that. But we know that in surgical patients, PCT is elevated regardless of infection because of what Levente showed you with the dump and pump things. And in these 3 RCTs, this could be highly have an effect on the results because they used absolute thresholds. So we and our team thinks that we have much more to do in this scenario because unnecessary antibiotics are a big problem in everyday practice because it is much more easier to give antibiotics than not give antibiotics, but because what will happen? That will happen.
So you mean that like these were all RCTs, and I like to think of RCTs as having like strict definitions, strict inclusion criteria, a strict adherence to the intervention protocol and stuff. And still, they are heterogeneous in their definitions of infection and their like interpretation of procalcitonin levels, or were there any?
Yes, they are heterogeneous because
uniformity?
it depends on the treating clinician. But this is where we live in. It depends on the clinician, and this is why I said that there was a predefined PCT protocol which can be overruled by the treating physician because it is not acceptable at this time that if there is a patient in septic shock and you look for the PCT and you look that, oh, it's nicely decreasing, I will stop the treatment, but the patient is on vasopressors, he is in shock, maybe less vasopressor than before. And in that situation, it's a big question that can you stop the treatment? This is why another direction from this is the not to severe septic shock patients, which Levente showed on his papers, because maybe in this patient population we can be more brave and say that, okay, the patient is getting better, okay, he's in vasopressor but getting better, PCT is down, inflammation is under control, I stop the treatment. So the heterogeneity becomes of this, the different types of infection, the different PCT protocols, and and the clinicians, because they have to opt for. And the guide or the protocol doesn't say that you should stop, you should start. It is strongly recommended, less recommended, and this is the phrasing in all of the protocols.
Okay, thank you. Can I have still have one? Can we jump to the exclusion criteria for your proposed clinical trial? Like, I'm totally, like, I don't know what I'm talking about. Just one question. Do you have, like, how much time does it take to be sure, like to confirm the absence of presence of these criteria in the ICU unit?
We can go through them, but there are some which...
The minimum, okay.
The minimum. I think minutes.
Minutes? Oh,
yes,
great.
because pregnancy, the antibiotic cardio pumps, these are minutes, and this is why we would must have something in our mind that what are we treating is in the inclusion criteria. But
and
it's
a very stupid question. So if we exclude all these patients, who is left? I mean, can you imagine like lots and lots and lots of critically ill patients without these criteria?
Yes, to tell you the truth, in the RCTs which we include in our meta-analysis, nearly the same was the exclusion criteria.
Oh, thank you.
Or if you look for, immunocompromised patients are a big question, but this is not listed here. We will talk about that, but you know, one of the limitations of this big meta-analysis, all the PCT trials, that they get rid of immunocompromised patients. Because in this situation, PCT elevation is not that high. By the way, the kinetics could be the same, so somehow we should include them. But the answer is that I don't have fears that we won't have anyone that we could include in our trial.
Great. Thank you. Thank you.
2 questions from my side. Márton, do you know any clinical conditions that elevate the PCT significantly, but not infection? And the second question, are you aware of any immunological effect of the procalcitonin in the host response to infection rather than inflammatory marker?
Yeah, for the first question, we have several conditions when PCT is elevated without infection. This ischemia reperfusion states like after cardiopulmonary resuscitation, burned patients, trauma patients. So when there is a big tissue injury and these so-called damage-associated molecular patterns are elevated in the blood, they initiate the same cascade as the pathogen-associated molecular patterns, and therefore elevates procalcitonin as well. And the second question was direct immunological effects of PCT.
Is procalcitonin more than an inflammatory marker? Does it have any other effect or role in the host response?
There are studies that maybe PCT has deleterious effects, maybe harmful effects, not just the biomarker, but maybe harmful effects. I read about that, but I don't know exactly in what way.
There were any differences between the different groups of antibiotics regarding the PCT and non-PCT group, like something that the difference was big in the case of macrolides and much smaller in the case of beta-lactams, or vice versa? Do you have any
no,
data
there was no
regarding
difference, which can highly have an impact on that is the pathogen itself. Because we know that gram-negative bacteria elevates PCT more than gram-positive bacteria. So we can see that, but regarding antibiotic therapy, no difference.
No difference, but a difference regarding the pathogen.
Yeah, this is a well documented. It is like we know that most of the cases in bacterial infection, the PCT elevates, in viral infection doesn't elevate. We know that is mostly because of the interferon elevation that suppresses PCT. And in viruses and in gram-positive infection, there is, in viruses substantial, but in gram-positive infection, there is an interferon elevation which makes this phenomenon.
For publication, my congratulations. I would still
Thank
like
you.
to comment a couple of things like this recurrence. This can be play of the numbers, because you had 90 versus 75 or something, and this was driven by a single study by De Jong from 2016. So the important thing, did you record the events or the patients? Because if you recorded the events, then that can be one patient with 10 events, and it messes up your statistics completely. So that is the first question, if you know that.
Yeah, they recorded the patients.
The patients.
Yeah.
Then you reported 28-day mortality, which is okay, but usually the patients that are in ICU, they are longer than 28 days in hospital.
Yeah.
For me as a clinician, would also be important to know how many were discharged alive. And then in first year, alive and out of hospital. Because then they are able to, and out of facility. Because then that means that the treatment was actually effective. So that would be my next step to see whether this data is available. Most likely not.
This not, but in hospital mortality we have. And it is in the article. It was reduced in the PC-guided group, but the difference was not statistically significant. But longer survival was not observed. So we don't know, but you're right.
Then what would be politically correct and attractive, and everybody would love you, is if you would also do the cost analysis. Reducing the ICU stay by 1.8 days or something you've shown, and you know from which countries people were, you could look up what is the cost of the hospitalization day.
Yeah.
Then would pay for the testing, because somebody could say, okay, PCT costs a lot of money. Why didn't you do it?
We tried to do. One of our outcomes was healthcare costs, and in the supplementary material we have the plot for that. The problem was that a few studies reported, I think only 5 from 26, and the reporting of the healthcare costs was very heterogeneous. Some just reported the cost of the antibiotic. Some reported all the summary cost of the therapy of the patient. But at the end, our brilliant statisticians made this standardized mean difference calculation. And as we mentioned in the article, we can say that it is not inferior, because this is what we can say from this data. But of course, this would be the best to calculate better, but we don't have data on that.
But okay, be pragmatic. You reduced by almost 2 days. You had 8,000. How many patients?
9,000.
9,000. So you had 18,000 patient days saved.
Yeah, you have to.
Times 500 euros and you're done. Or, I don't know, 1,000 euros. Very easy. Then for the randomized trial, okay, so you focused only on ICU patients in your review?
Yes.
Okay.
In our meta-analysis, in our review, we investigated patients outside the ICU.
Because I have checked, you didn't include any of the trials with heart failure. So basically, if the patient will enter ICU, then the chance to be treated with the antibiotic is very high. Let's be honest, we tend to overdo it usually. Now, in my opinion, the more relevant problem are the patients that enter the hospital but not ICU and have the suspicion of infection. So, okay, you can do the randomized trial as you have planned. The comments would be, which other biomarkers would you test? Would you do any genetic testing for transcription of the gene for procalcitonin to see whether this may play a role? and whether you are planning to do it in multiple centers in multiple countries, because otherwise you are testing boutique centers in one country. And but what I would do, because there is evidence for that in heart failure, which is my topic, that inappropriate use of antibiotics increases mortality. And there was one trial published that was Impact HF that didn't show benefit of PCT-guided therapy. So maybe the patients that enter the hospital with acute exacerbation of COPD, heart failure, with suspicion of infection, because this is the public health problem. This is the bulk of the patients. So why don't you consider firstly systematic review in those populations which comprise 5 to 10% of general population, that's heart failure and COPD, and then to see whether you can tease out a good randomized trial?
We would consider it. Thank you.